To the last segment of the diagnosis proposals. I know most of you are used to us getting out early and trying to finish sooner, but had a lot of topics this time. And be prepared for the March meeting. Please anticipate the same. Just wanted to give you a heads up because the proposals are coming in. And again, like I said yesterday, they're not fewer proposals. There's actually more proposals. So with that, I'm going to turn the podium over to Cheryl Bullock, who will introduce our next topic and speaker. Cheryl?
Okay, our next topic is primary sclerosing cholangitis, and it is found on page 75 of your topic package. Our speaker is Ms. Patricia Stolfus. She has worked in hospital coding for over 30 years, coding manager of Pinnacle Health Systems in Harrisburg, Pennsylvania, and she is also a mother of a PSC patient and currently a mentor and coordinator of the PSC Partners Seeking a Cure.
Good afternoon, everyone. First, I'd like to thank Cheryl and Donna for helping me get to this point today. It took some doing, but we finally did it. Also, my world seemed to be colliding today. We talked a little bit earlier this morning about outguides. I also remember 3 code books on my desk and cutting out updates and taping them in with the accordion folder, so I'm not sure how many of you remember that. But, and this meeting has been on my list of things that I've wanted to do over the years, so it's, I just didn't expect it to be as a presenter that I would be here. So as Cheryl said, I am personally interested in this topic as my son does have primary sclerosing cholangitis, but I'm here today also as a representative of PSC Partners Seeking a Cure, which is a nonprofit organization that supports PSC patients and caregivers, funds PSC research, and seeks to address the many unmet needs of people affected with PSC. The request for this code we have made in conjunction with Dr. Chris Bolus, who is a PSC specialist at the University of California, Davis. To just give you a little bit of background and understanding of what PSC is, it's a rare, chronic, progressive disease that affects the bile ducts both inside and outside of the liver. With PSC, the bile ducts are inflamed, causing scarring and narrowing or sclerosing of the affected ducts. As the scarring blocks more and more ducts, the bile becomes trapped within the liver, damages the liver, and can result in fibrosis and cirrhosis and eventually liver failure. There are currently no treatments to slow down the progression of PSC, and many patients will need a liver transplant. However, the interesting thing about PSC is sometimes it reoccurs in the transplanted liver. It predominantly affects men 30 to 40 years old, but can also occur in children, such as my son. He was diagnosed at 16. It also affects women and the elderly. PSC affects about twice as many men as women. Almost half of PSC patients do not have any symptoms when they're diagnosed, so diagnosis is made through a combination of blood tests and imaging. Over 3/4 of PSC patients have overlapping inflammatory bowel disease, either ulcerative colitis or Crohn's. It's also associated with other autoimmune diseases. Although many patients do not experience symptoms when they're first diagnosed, depending on the disease progression, and there is no typical progression, I can tell you that, the symptoms are often incapacitating as the disease progresses. There's been no medication found to slow down the progression of PSC at this point. So currently, PSC codes to K83.0, cholangitis, which is a catch-all code for all types of cholangitis. We're asking to have K83.0 further subdivided in order to create a specific code for PSC. We know that the clinicians and the researchers currently diagnose, investigate, and they do document PSC as its own disease in medical records. It was first documented over 150 years ago. Also, the WHO has already made the change for ICD-11 to create a specific code for primary sclerosing cholangitis. However, we can't wait for ICD-11. We need to have something now in CM. We're currently at a crossroads in medical research, patient efforts towards understanding the disease and finding effective treatments, as well as supporting and advocating for PSC patients. A specific code for PSC will aid in all of the above. Pharmaceutical companies and researchers are beginning to conduct clinical trials for PSC. It's imperative for the researchers conducting these trials to get standardized data. How do we get standardized data? With a code. Also, researchers cannot track the prevalence of PSC and cannot solidly assist with outcomes research. The risk of colon cancer increases with those patients with the PSC-IBD overlap and requires close annual monitoring. My son at 16 has already had almost 10 colonoscopies, or since he was 16, has had 10 colonoscopies. PSC is also associated with an increased risk of cholangiocarcinoma, or cancer of the bile ducts. It's often most diagnosed too late for any life-prolonging treatments to be possible. A specific code will help facilitate the discovery of biomarkers that are associated with the PSC cholangiocarcinoma combination. As I mentioned earlier, the disease progression varies widely from patient to patient. Some patients live virtually symptom-free for years. Other patients may suffer from debilitating symptoms and progress very quickly to transplant. Excuse me. More patients are transplanted every year for PSC than for either of the other autoimmune liver diseases, and at a younger age. PSC is commonly referred to as the last black box of liver disease because even though there are theories about the etiology, there are no substantiated causes for PSC, and therefore nothing has been found to slow down disease progression. Currently, treatments simply manage the symptoms. A specific code would help classify progression rate and allow a better understanding of markers associated with different rates at what appears to be erratic disease progression experienced by the PSC patients. Although PSC affects 30 to 50,000 people in the United States, the disease is still not well understood. There are, however, several clinical trials underway that aim to slow the progression of the disease and reverse liver damage. Concerted efforts, including multi-center PSC consortia and disease-specific registries, now seek to push research forward from the point of diagnosis onward. Because of the lack of a specific code, researchers are unable to specify the correct cohort of patients needed. Researchers and thought leaders have commented on the problems they have faced when identifying cases from administrative data for the epidemiological studies or quality improvement programs involving PSC. So a specific code is an essential contribution to make for patients with PSC to be treated with equity and that effective therapy can be identified, investigated, and implemented. So on a side note, this also happens to be PSC Awareness Week. And so as a coder, personally, what better way to create awareness for PSC than to create a specific code for it? So as the motto of PSC Partner says, together in the fight, whatever it takes, we will find a cure. And having a specific ICD-10 CM code for that will help us in that fight. Thank you.
Okay, I will continue with the code modifications that are being proposed. So at K83, other diseases of the biliary tract, for code K83.0, of cholangitis, basically is being proposed to delete all inclusion terms that are currently there. A new code is being proposed at K83.01, primary sclerosing cholangitis, and new code K83.09, other cholangitis, which is all the remaining ascending, primary, recurrent, secondary will be included under the K83.09. Are there any questions or comments from the audience?
I have a question, and it's a clinical one. So, well, first, I'd like to note that I have seen this condition and coded it at various points, and I always kind of wondered why it was, quote, lumped in with just all colitis, all other
Me
types
too.
of cholangitis. But my question is then a technical one for the coding side. Does this kind of cholangitis, this primary sclerosing cholangitis, does that typically involve other disorders of the gallbladder? Are you likely to see it with cholecystitis or calculi in the bile ducts, things like that?
It affects the bile ducts inside and outside the liver, but it is a specific liver disease, and I don't know that I can answer anything specifically
that's why I
to
was
gallbladder. Yeah.
A little concerned about that, because I know...
I mean, from what I've seen and what I've known, there are some people have had their gallbladders removed because of it. But I don't think that there's anything specifically that's ties the two of them together.
The reason I wondered is because we have notes and instructions and things like, so if you see cholangitis with the bile duct calculi, you're supposed to go.
Right,
you know that,
right.
So,
But it's
it
just,
sounds
it
like
is
this wouldn't cause
specifically the
that.
stenosing and the sclerosing of the liver bile ducts. So it is, I mean, coding-wise, totally separate from.
Oh, no, I understand that.
Yeah.
It's just I was concerned that if we create a separate code for primary sclerosing, that people will still see the notes about if you see it with bile duct calculi, you should code to cholecystitis or whatever, and then we would miss the point of having a separate code. But if PSC doesn't occur with bile duct stones, I mean, I understand that there's stenosis or whatever, but it's not a stone thing, so then we don't need to worry about it. Okay, that's why I asked.
No, if that was your question, yeah, I'm sorry about that.
Just a coding question. Since it seems you're looking to take the opportunity to expand the cholangitis section, I wonder if it would be reasonable to talk with the other GI societies and develop a subcategory for primary cholangitis and another one for secondary, and then have specific codes at a 6-digit under those sections.
Okay, thank you. Moderator, could you open the phone lines for any comments or questions, please?
All lines have been unmuted.
Are there any comments or questions from the phone lines? Not hearing any. Moderator, you could...
This is Dr. Reamer. Can you hear me now?
Yes, Dr. Reamer.
So I actually would like to also piggyback on Linda's comment. So one of my concerns is that when you have PSC, it's possible that somebody could also have choledocholithiasis. It's kind of independent and incidental, and you would not want to go to the K80. You would want to actually be able to do PSC in addition to, so you need to figure something out with that.
Okay, I think in working with Trish, we will do additional clinical research and see if there is a direct correlation, if we can get something that will substantiate that coding instruction. We'll take a look at it.
Okay, great. Thanks.
Thank you. Are there any other comments or questions from the phone lines? Just don't hear. Moderator, you can close the phone lines, please. Thank you.
Thank you, ma'am.
Okay, the next series of proposals are from our pediatric group. There's about 4 to 5 proposals that are going to be presented. The first proposal is going to be found on page 57 of your of your topic package, Neonatal Metabolic Disturbances. Neonatal metabolic disturbances are transitory conditions that occur during birth or shortly thereafter. The ICD-10 codes that are currently found in Chapter 4 do not adequately reflect metabolic disturbances in the major serum electrolytes. Codes found for disturbances in sodium balance and disturbance in potassium balance that are found in Chapter 16, again, do not differentiate between hyper and hyponatremia or hypokalemia. These conditions all have different etiologies, consequences, and treatments with different level of urgency. Fluid management and sometimes medications are used to treat these conditions. The American Academy of Pediatrics is requesting the addition of codes in category P74. The code proposal that is in your topic packet does have some corrections, and we will make the final corrections on these. So I'm going to talk them through, but the final, if approved, will be corrected. For P74, other transitory neonatal electrolyte and metabolic balances, at P74.2, disturbances of sodium balance, there actually is going to be only 2 codes needed. P74.21, hypernatremia of newborn, and P74.22, hyponatremia of newborn. P74.20 and 29 are not needed, and they will be deleted, not included in the proposal. Same situation for P74.3, disturbances of potassium balance of newborn. New codes will be P74.31, hyperkalemia, and P7432, hypokalemia of newborn. P7430 and 39 will not be included in the new code proposal. Additional corrections at P74.4, other transitory electrolyte balances of the newborn. The new code is going to be P74.41, alkalosis of newborn, with an inclusion term of hyperbicarbonemiia. There will be a new subcategory of P74.42, disturbances of chlorine balance of newborn, with new codes P74.421, hyperchloremia of newborn, inclusion term hypochloremic metabolic acidosis, with an excludes 2 note of late metabolic acidosis of the newborn. Additional new codes will be P74.422, hypochloremia of newborn, and P74.419, disturbances of chlorine balance of newborn unspecified. I'm sorry. 429. Yes, again, the coding, we have to make some adjustments within the code, numeration of the code, so we got off. Is there any comments from the audience?
The Academy saw a need for this degree of specificity because unfortunately the codes as they currently stand don't clearly clarify the conditions, and as most of you are probably aware, different conditions, different treatment options, and different needs. So as one can be hyper or hypo or normal, we just needed the codes to identify those.
Thank you. Moderator, can you open the phone lines, please?
All lines have been unmuted.
Are there any comments or questions from the phone lines?
For the P70.41, we have one new subcategory, but don't we need another new subcategory? There seems to be something not right with that structure. We're including a new subcategory for disturbances, and don't we need something else for other alkalosis of newborn?
I can take a further look at that. The error was noted prior to presentation, so I was discussing it with Dr. Linzer, and we could take a closer look at to clarify the numeration for the codes, the proposed codes, to address what you're saying. Thank you. Hearing no other comments, I'll move on to the next topic. The next one is intrauterine exposure, which is found on page 51 of your topic packet. Okay. The American Academy of Pediatrics and the West Virginia Perinatal Partnership, a statewide organization of over 300 healthcare professionals and private and public health agencies, are working to improve perinatal health. Working collaboratively, they are proposing new codes to identify specific substances known to cause problems and increase care utilization for the neonate population. It is being proposed that the P04 category be expanded. The new codes would allow more specificity to determine trends in neonatal outcomes from intrauterine drug exposure. Of course, substance use, particularly during pregnancy, is a national crisis requiring state-level tracking and reporting. Accurate and specific ICD-10 CM coding is vital to these efforts. The Protecting Our Infants Act of 2015 seeks to address this need by, among other things, mandating that the Health and Human Services help states improve their availability and data collection for surveillance activities regarding perinatal drug use. Currently, state and national agencies and organizations are limited in their attempts to track intrauterine exposure and withdrawal symptoms due to a specific substance, as the current code P96.1, neonatal withdrawal symptoms from maternal use of drugs of addiction, does not make that distinction. In ICD-9 CM, for example, code 760.72 indicated that the fetus was exposed to narcotics. In ICD-10 CM, the code crosswalks to P04.49, newborn affected by maternal use of other drugs of addiction. The requesters also, in addition to expanding the P04, the requesters are also requesting that a code from P04 category be allowed to be reported with the appropriate withdrawal code from P96 to be able to give a clear picture of a baby in withdrawal and the specific drug causing the withdrawal. The American Academy of Pediatrics and the West Virginia Perinatal Partnership are proposing the following code expansion. At P04.0, there is a note that is being suggested to be revised. The revision will state, newborn affected by reactions and intoxications from maternal opiates and tranquilizers administered for procedures and during pregnancy or labor or delivery. And also being proposed to add an excludes to note that the excludes to will indicate newborn affected by other maternal medication, which is P04.1-. There's a new subcategory being proposed, P04.1, newborn affected by other maternal medication. There is a proposed to delete the current inclusion terms there now, newborn affected by cancer chemotherapy and newborn affected by cytotoxic drugs. It is also being proposed to add a code first note to code first withdrawal symptoms from maternal use of drugs or addiction, if applicable. And it was brought to my attention that we're going to also include the P96.2 within that code first note. The additional revision of an excludes note from excludes 1 to excludes 2, maternal anesthesia and analgesia in pregnancy, labor, and delivery, and maternal use of drugs of addiction. There are several new codes that are being proposed at the P04.1. 1.1, newborn affected by maternal cancer chemotherapy. 1.2, cytotoxic drugs. 1.3, anticonvulsants. 1.4, use of opiates, etc. They're all defined in the packet. There's also a new subcategory of P04.4, newborn affected by maternal use of drug of addiction, with new code P04.40, newborn affected by maternal use of unspecified drugs of addiction, and new code P04.42, newborn affected by maternal use of hallucinogens, with an additional excludes note. It is also being proposed that the current note that's there, we will be deleting withdrawal symptoms from maternal use of drugs of addiction. Final new subcategory of P04.8, newborn affected by other maternal noxious substance, with one new code proposed at P04.81, newborn affected by maternal use of cannabis. Dr. Linzer?
So as you can see from the introduction, there is quite a need to track these issues as it's becoming a significant problem. And instead of trying to identify a number of different agents as drug of abuses as opposed to therapeutic drugs, we thought the best approach would be to identify general categories of the codes of drugs that the child may be affected by. And then the clinician, if the child is going through withdrawal, will be able to document in the chart if this is due to addiction or therapeutic use. So let me give you an example. A mother has hemoglobin SS disease, and the mother routinely takes opiates for control of pain for the sickle cell disease. Child's born and has withdrawal. So the child is affected by maternal use of opiates, but it would get the P96.2 because she was taking them therapeutically. So we would clearly be able to identify, A, the child's in withdrawal because of therapeutic use, and what the agent is that the child was affected by. The alternative is the mother who is a heroin abuser, and the child goes through withdrawals. In this case, we'd still be able to identify that the child was affected by opiates, but then the clinician would be able to identify an infant of a substance-abusing mother, and you'd use the P96.1 that it's a withdrawal from maternal use of drugs of addiction. So since many of these medications can cross over therapeutic versus addictive use, the clinicians will be able to clarify in their notes if the child's going through withdrawal, therapeutic use versus non-therapeutic use, and we'll also have the ability to better identify the general classification of the drugs that are affecting the child. Now, if the child's not having any withdrawal symptoms, but had some effect from the medications, again, we'd be able to identify what the newborn was affected by through the maternal use.
Thank you. Any other comments from the audience?
Teresa Rahanic, Intelligent Medical Objects. At P0411, I would like to request that maybe change cancer to anti-neoplastic, as throughout the classification, it's typically references anti-neoplastic chemotherapy. And then the other is just a question for the drugs of addiction section at P04.4. We have a unique code for cocaine already established in the book, but do we need to grab the, sedative, hypnotic, antioxylytics, and amphetamines in the drugs of addiction section, or does that information need to be captured, or because otherwise you're going to end up with other drugs of addiction in the newborn?
I believe in the proposal the cocaine was moved in to this P04.4. No, but given an extra digit, I forget if I think it's 4.1. So it sits under here. So, yeah, so it's already there at 4.1. So it follows. But the reasons we don't bring the others is because they may be used for therapeutic purposes or they may be used for non-therapeutic purposes. So instead of taking a sedative hypnotic, for example, or an anxiolysis and putting it under drug of addiction, the mother may have been taking them therapeutically and the child's affected by it. So we're able to identify that the child was affected, but these drugs could fit in either therapeutic or addicted. Cocaine, for example, hallucinogens, for example, are medications of non-therapeutic use.
Correct. So my question is, if, that's not what I'm asking, so the header at P04.1 is newborn affected by other maternal medication. So if my patient I'm coding is addicted, not using medication for an amphetamine, I am going to code that to P0449, and you aren't going to know that it's amphetamine in the newborn, because I wouldn't code P04.1 because it's not a maternal medication. Or the P04.16 because that's maternal medication. If you want drugs of addiction, I would recommend in
But
P04.4.
you have an excludes note too that will allow you to code both.
It's still not a maternal medication.
The mother was taking the
Not under therapeutic guidance.
No, it doesn't, but
That's what I take P041 to mean, so if I misunderstood.
yeah, that wasn't the intent.
Well,
The
that's how
intent
I
was that
understand that.
the mother was taking that medication, as opposed to medications that are clearly classified as drugs of abuse.
I still don't make that sense.
Hi, June Bronner with Intelligent Medical Objects. And I think the way that excludes notes are and the way this list is, it's not as clear unless you're here listening to this conversation. So if there's a way to make it clear, because along those same lines, if the rest of the context of the patient's record was clearly identifying one of those drugs as being addicted, I would look to the P04.4 to find that and not look at the 041 and for the further information. So-
Okay, thank you. And again, please put those comments, so again, Dr. Lenz and I, we can, as a team, again, go back and discuss and see can we address all issues. Moderator, could you open the phone lines, please?
All lines have been unmuted.
Are there any comments or questions from the phone lines?
Just a couple of quick things. PO 4.19 needs to be PO 4.10, and you do need a PO 4.89. But I think addressing the other issue, if there's just a PO 4.43, you can include cocaine there. You just need another code.
Okay. Thank you. And again, if you could put those comments in writing so we can make sure we address all issues. Thank you. It exists. Are there any other comments from the phone lines? Thank you. And I'll move to the moderator. You could close the phone lines, please. The next proposal is found on page 47 for immunization not carried out. This proposal was originally presented in March 2017 CNN meeting. The American Academy of Pediatrics supports the recommendations received during the comment period, and a revised proposal is being submitted for further considerations. This proposal addressed the need for medical providers to show that a delay in vaccine administration is related to non-delivery or insufficient supply of a vaccine. This is to follow the guidance of the Advisory Committee on Immunization Practices that the schedule was not administered. So at category Z28, immunizations not carried out and under immunization status. Subcategory Z28.8, a new code is being proposed at Z28.83, immunizations not carried out due to vaccine delivery, with inclusion terms of lack of availability of vaccine, delay in delivery of vaccine, or manufacturer delay in vaccine.
You're right, I should have come up there.
I told you.
This is a quality metrics issue as much as anything else. Children are supposed to follow a particular vaccine schedule, and that schedule has been interrupted a number of times because of the lack of availability of the particular vaccine. So by having a unique identifier to indicate, yeah, I wanted to give it, but I couldn't, and here's why I couldn't, then it shows that the intent was there and the reason why you couldn't administer it.
Thank you. Moderator, could you open the phone lines, please?
All lines have been unmuted.
Are there any comments or questions from the phone lines? Not hearing any, moderator, you could close the phone lines. Our next proposal is found on page 42 of your topic packet. It's encounter for screening for certain developmental disorders in childhood. At the March 2014 Coordination Maintenance Committee meeting, AAP requested new codes for Z13.4, encounter for screening for certain developmental disorders in childhood. Based on comments received and further review, that proposal was represented at the March 2017 CNN meeting. AAP has subsequently submitted another proposal for further modifications to this code category. So this proposal is reflective of previous changes as well as the additional requests. The AAP noted that encounters for developmental screening is the main or only reason for the encounter. It normally occurs outside of the routine infant or child exam. AAP's request for additional code modification is in response to Medicaid's implementation and a developmental screening measure or Medicaid child care course set that is required for patients receiving benefits through their state Medicaid program. Both developmental and autism screens are part of the Academy's recommendation for preventive health care. So the Academy respectfully submits a revised code proposal for new codes under Z13.4 to specify whether the screen is global delays or autism, and also they're requesting to revise the exclude note at Z13.4 to allow the use of both codes during routine health exams. So, because this is a combination of the prior presented proposals, I have included the original part of the original request at the Z00.12. It was proposed to delete the encounter for developmental testing of infant or child, with 3 inclusion terms that would remain the same. At category Z13, encounter for screening for other diseases and disorders, new subcategory Z13.4, encounter for screening for certain developmental disorders in childhood, with an inclusion term, of course, of encounter for screening for developmental handicaps in early childhood. And is also being proposed that the inclusion term of encounter for developmental testing of infant or child. It's also requested to revise the excludes notes from excludes 1 to excludes 2 to be able to code with encounter for routine child health examination. 4 new codes are being proposed. Z13.40, encounter for screening of unspecified developmental delays. Z13.41, encounter for screening autism. Z13.42, encounter for screening and global developmental delays and milestones, with an inclusion term of encounter for screening for developmental handicaps in early childhood. And the last new code, Z13.49, encounter for screening of other developmental delays, is being requested.
And again, these are very unique areas that may be and generally are the primary purpose of the encounter. So there could be a concern that the child has autism and may see the primary care or a specialist, so they're not having a routine health screen, they're having a specialty screen to determine if they're autistic. Along those same lines, the child may be seen because of delayed milestones and are again seeing a primary care provider or a specialist exclusively or principally for that reason to determine if they have delayed milestones, to determine if a condition exists.
Thank you.
My question is, so if the patient has delayed milestones or has a symptom identifying them to need additional testing, screening, that seems to go against the definition of screening, which is for screening is the testing for disease or disease precursors in seemingly well individuals so that early detection and treatment can be provided. So if I have a symptom, I'm going to use the symptom code. I'm going to use delayed milestones or whatever the problem is for prompting this. Could these go in an encounter for examination rather than in screening?
There may be a concern that the child has delayed milestones or autism, and these are being screened for at a much earlier age now. There are some screening techniques that can be done in the newborn period. So the purpose of the encounter is to determine if the patient has autism or developmental delay. If they've already been identified with a developmental delay, then they're not going to be screened for that. So if the physician is documenting developmental delay in the medical record, there's no reason for them to have a screening for developmental delay.
But if they have developmental delay and they're trying to determine if they already know there's developmental delay,
then we're not screening for developmental delay. If the R code for developmental delay is already in the patient's medical record, you're not screening to see if they have a developmental delay.
I agree with you, but that's what I think you're saying with the screening. There's something that's pointing that we now need to do this, or is it I have a patient who has a sibling that has autism, and now because this child's this age, we want to screen for autism in a sibling, and the second child doesn't have any symptoms yet, or identifying delay.
So a child may be delayed in speech, okay? And they may be delayed in speech just because they're normal, slowly picking up their speech, and suddenly become an orator at 6 and you can never get them to be quiet. Or there may be a developmental issue. So the fact that they may be identified with delayed speech, you would try to determine if this is a delayed milestone or not. So they would have an encounter for screening for global developmental delay. The symptom in and of itself of delayed speech doesn't tell you anything. And you're trying to determine if that delay in speech is something or not.
Right, so the delay of speech is the reason for the encounter. So to me, that's the principal, primary reason they're there, and then the encounter for, I don't know how to phrase it.
I think part of the concern is with the word screening, because in the example, and if you think about how screening is in other areas of ICD, is once there is a sign or a symptom, we move out of a screening phase. And an example that comes to mind is for mammograms, as far as if you go present without any symptoms, then it's considered you're there for that screening, whereas if you actually have a pain or something else that was really not very descriptive and doesn't really tell you that you have an issue, it's no longer really that screening, you have the pain. And I think that's kind of the concern for this area, is the encounter for screening, as far as are there other signs or symptoms that, to your point, that don't really tell you much, but they have other sign or symptom codes, and is it really screening? Because the term screening in ICD has a very specific meaning, and I think that's kind of an overall concern.
Right, and I appreciate what you say, and the problem can be varied. The child sits by himself. Is he autistic? Just because he sits by himself. And he's not social. So are you going to say not social? as their diagnosis code because that's a symptom? No, you're going to do a screening to see if they're autistic. You have a child who isn't crawling. That's not necessarily motor delay, but you're concerned, are they having delayed milestones? So I appreciate what you're saying as far as there may be a symptom of breast pain, so you're no longer necessarily using the screening code. But these are very common situations in the pediatric world where there's a concern that may not be codable, and the child needs to be evaluated outside of a routine health exam to determine if these problems exist so that the appropriate care can be directed.
So is suspected a better word than screening, as we have in other areas?
Well, these fall under the screening codes, and it's exactly what it is, that somebody's coming in to be evaluated to determine if these problems exist outside of a normal health exam. So in the old days, as part of the routine exam, we do the Denver Developmental screen, which isn't done anymore. And that was just part of the routine testing. Well, the testing has become so much more detailed and complex now that it can't be done generally during a routine test. So the physician may say, okay, you have these concerns, let's bring your child back. I have some questionnaires I want you to fill out. I have some questionnaires I want the mother to fill out, the grandmother to fill out, and all these people to fill out, and I'm going to do some testing on your kid to determine, do they have delayed milestones? Do they have autism?
Thanks for the additional information, and and I guess still thinking about this in the ICD, suspected for me, and I'll put these comments in writing.
Certainly.
Comes to mind more than just a screening, and that's from the terminology of the system.
Thank you. Yes, please. And it gives us a lot to take back and to make sure we try to meet the needs of both. Let me go ahead and do the additional screening proposal, and then we will open the phone lines for comments and questions. The final proposal is found on page 54, because we may have the same issue that may be a concern. This is mental health screening for depression and other. Mental health screening, specifically depression, is now routinely recommended by both government and non-government entities responsible for developing preventive measures and standards. The HEDIS data includes a rate of depression screening performed on adolescents and adults as part of its measures. It is important to have the ability to report the appropriate ICD-10 CM code to differentiate between depression screening and perinatal or maternal depression screening. In response to this request, the American Academy of Pediatrics, the National Center for Health Statistics, proposes to reactivate WHO ICD-10 code Z13.3, special screening examination for mental and behavioral disorders, to meet this requirement. So at Z13, new subcategory Z13.3, encounter for screening examination for mental health and behavioral disorders. In new code Z13.30, encounter for screening examination for mental health and behavioral disorders unspecified. New code Z13.31, encounter for screening of depression with inclusion terms of encounter for screening for depression for child or adolescent, and encounter for screening for depression adult. New code Z13.32, encounter for screening for maternal depression with an inclusion term of encounter for screening for perinatal depression. New code Z13.39, encounter for screening examination for other mental health and behavioral disorders with an inclusion term of encounter for screening for alcoholism and encounter for intellectual disabilities.
So again, these are concerns that may have been raised by the parent or another individual to determine if the patient has these problems. Just like with the autism and developmental milestone screening, there is a concern without any specific symptoms. Again, these also follow the HEDIS guidelines for making determination if the patient has these conditions. So these are quality metrics monitoring as well. Can you tell a child's depressed? They sit and they watch TV, they don't talk to their friends. They're doing bad in school. Are these symptoms? No, not. But you're concerned the child's depressed. You're concerned that the child is being adversely affected because of maternal depression, perinatal maternal depression, which is becoming more identified as a significant family effector issue. Again, is the mother just moping around? Is she ignoring the children? You know, there's no symptom codes for these, and these again are screening to determine if these conditions are present or not. I can't take credit for the alcoholism, it was already there.
Yeah, thank you. Yeah, that was under WHO as an inclusion term. Moderator, could you open the phone lines, please, for any comments or questions?
Amy Blum again. Hello?
Yes.
Yes, this is Amy Blum again from NCHS. I agree with the previous comments that these screening codes do contradict not only official coding guidelines, but specifically why some of the screening codes were removed from 10 initially. What you are looking for are in the R codes. We have R620, R625, specified delayed developmental things. We've got socioeconomic factors. A screening code is never supposed to be used if there is any sign, symptom, or condition for which a particular diagnosis is suspected. They are only to be used if there are no signs or symptoms and it is for a routine exam. All of these proposals really belong in Chapter 16. And if there's some kind of a HEDIS measure that is in conflict with that, then that is a problem because that does go against official coding guidelines.
Okay, thank you, Amy.
If the child had delayed milestones, then you would not be screening them for delayed milestones. If the child is sitting alone in class and not participating in class, there's no symptom code for that. You're going to be screening the child to see if they're depressed or not.
There are signs and symptoms for all of these things. The reason that the child is being evaluated is because there is a behavior or a symptom or some abnormality in their development or in their interpersonal relationships that is cause for concern. It is not a screening.
This is Dr. Erica Reamer. So it's actually more complicated than this because there are times when you're mandated to do certain kinds of screening, like you're supposed to, like for instance, the emergency department, you're supposed to screen for whether or not someone is being abused at home, and it's a screening. So I think part of the problem is some of the quality metrics may be looking to see if people are doing routine screening, and there may also be kids who have a trigger that's causing you to do the screening at that time. I guess the question I have is, are there CPT codes to pick up the screening such that if a child comes to your office and a screening is performed, that the quality metrics could pick up that the screening was being done in appropriate situations without having a Z code for it? And the second question I have is, if they rule in, then the screening code no longer would be utilized. You would just use the autism code or the developmental delay code, and the screening would go away?
Yes, exactly. In both cases, the CPT code should cover the screening because it is a procedure being performed, and if the diagnosis is confirmed, then the diagnosis is what's supposed to be used.
We will definitely take all those things back. We'll go back to the table and see can we address all of those issues. Again, please put your comments in writing so we can have a framework for which to work with, and so that we can address the requester's needs as well as stay within the guidelines of coding. And I think that's it for the AAP. Tracy. Next, I do want to call Tracy back up for another proposal as well.
Okay, if everybody could turn to page 34. The next topic is cyclical vomiting syndrome. Cyclical vomiting syndrome is described by episodes of severe vomiting that have no noticeable cause. Episodes can last for days or hours and alternate with symptom-free periods of time. Each episode tends to start at the same time of the day, last the same length of time, and occur with the same symptoms and level of intensity. Cyclical vomiting syndrome may or may not be related to migraines. Treatment usually involves medications including anti-nausea and migraine therapies that may help lessen symptoms. Currently in ICD-10 CM, cyclical vomiting is indexed to code G43A0. Cyclical vomiting, not intractable. These codes fall within the code category of G43, migraine. In 9CM, cyclical vomiting, not related to migraines, was captured under code 536.2, persistent vomiting. Code 536.2 crosswalks to ICD-10 CM to code R1110, vomiting unspecified. This code does not seem to adequately represent the clinical significance of the disorder in the treatment of cyclical vomiting syndrome not related to migraines. These changes have been requested by the Coding Clinic Editorial Advisory Board, and the American Academy of Pediatrics has reviewed and supports this proposal. So at G43.A, we are adding an excludes one note for cyclical vomiting syndrome, R11.15. And at category R11, nausea and vomiting, we're adding a new code at R1115 for cyclical vomiting syndrome, as well as adding an excludes one note to exclude the cyclical vomiting at G43A. Are there any questions in the audience? Operator, could you open the phone lines, please?
All lines have been unmuted.
This is Dr. Reamer.
Yes.
Can you put the slide back up, please? I'm sorry. You know, there's a lag when you're watching it and you're doing it. Well, actually, I guess I could just go to the page. So it seems like it's backwards to me. It seems like cyclical vomiting syndrome is what belongs in migraine, and cyclical vomiting without syndrome belongs in signs and symptoms.
So you're requesting that R1115, that's the incorrect?
I'm not requesting. I'm trying to sort this out, and I may be mistaken. It seems like cyclical vomiting syndrome is a migraine equivalent, and cyclical vomiting would be a sign or symptom that you don't know what it's from yet. So it seems like it's backwards.
All right, well, would you please put your
Of course.
comments in writing, please?
Thank you.
Thank you. Linda?
I just wanted to second Dr. Reamer's comment. I didn't think about this, but when she mentioned it, it does seem backwards. If someone has a cyclical vomiting syndrome, does that word syndrome necessarily imply that it's related to migraine?
No.
Because just cyclical vomiting by itself, does that imply that it's related to migraine? When I'm coding this chart, do I need to see the word syndrome to use the R11.15? No, they're adding code R11.15. I understand that cyclical vomiting is sometimes related to migraines and is sometimes not related to migraines. So far, so good. But in calling it cyclical vomiting syndrome, that makes it a syndrome, makes it sound like it's not a symptom, for one thing.
Okay.
Right? And also, I don't know if I'm going to see the word or the clinical term syndrome. So maybe we need different wording?
Would you suggest maybe without migraine?
Yeah, more like cyclical vomiting.
I have a suggestion to want to make our LabCorp. I would do something like migrainous cyclical vomiting for the G43 category code, and then remove the word syndrome from the R11.5 or R11.15, if you consider that.
Okay. Thank you, Tawana. Could you please make sure you
Remember-
send that in writing?
Remember that you have to get the doctors to actually be documenting that way. And I can tell
never
you
forget
as
that
a
for 1 minute.
physician, I can tell you as a physician, cyclical vomiting syndrome to me is the migraine equivalent. And cyclical vomiting is, I don't know what it's from yet, and I'm doing a workup.
Okay, thank you, Dr. Reamer.
The International Classification of Headache Disorders does classify cyclical vomiting syndrome as a condition related to migraine. So I think maybe you should refer back to that classification also for more information about where, because it looks to me like cyclical vomiting syndrome belongs at G43A.
Thank you, Teresa. Are there any more questions on the floor?
They gotta have a lady.
Okay. I'm going to turn the podium over to Donna.
Okay, we have one more pediatric-related proposal, and you'll find that on page 93. And this is a representation of this proposal. As you know, we had a proposal last year and implemented a new code October 1, 2016 for Zika virus, the A92.5, and that was consistent with the WHO proposal to update ICD-10, in addition to proposing the creation of a new code for the Zika virus infection. They were also proposing a new code in the pediatric section for the congenital Zika virus. We went forward again with the A92.5. We did not go forward with the pediatric related code because WHO actually held over the entire proposal for further discussion this year at their October meeting. So next month, WHO for ICD-10 will be considering the A92.5, which again we've already implemented, but also new codes for other pediatric-related Zika virus conditions. We've seen the proposal, and so we've taken the proposal originally put forward by AAP and a CDC work group, modified it to incorporate the WHO additions that are being presented and discussed next month, and are representing it here. And as we indicate in the write-up, should the WHO proposal for ICD-10 not be fully vetted, we will then take a look at what we should do in 10CM. But we wanted to bring the proposal forward now during this update cycle, because if we waited until October, the proposal would be held over until March, which would be for consideration for the following federal fiscal year. So again, the A92.5 has already been implemented in ICD-10-CM. There is an additional excludes note being added there for the new code P35.4, which is under consideration by WHO. And then in the original proposal from AAP and the CDC work group, adding new codes P0021 and P0029, with the 21 obviously being specific to the Zika virus. New code P35.4, congenital Zika virus infection. And additional note at Q02, microcephaly, to also identify the congenital Zika virus disease, and then at Z20, contact with suspected exposure to. Under Z2082, we would be proposing a new code Z20-821, contact with and suspected exposure to Zika virus. Are there any comments or questions from the audience on this updated proposal?
Teresa Rahanic, Intelligent Medical Objects. Just a quick question. I'm a little confused what the difference between P0021 is and P35.4. Newborn affected by maternal infection with Zika virus code additional manifestations versus the P35.4, where you have congenital Zika, and you use additional codes for manifestations.
Dr. Lindsay?
What's the difference between P0021 and P35.4?
Between the newborn affected by maternal infection with Zika virus and the Q02, or the P35?
The P35.4.
So the newborn of the fetus could be affected and could abort because of the infection, and the child may develop Zika-related congenital conditions such as microcephaly because of the infection that was caused in utero. This was codes that were developed in collaboration with the CDC to classify these type of patients. So the CDC working group felt that this expansion was appropriate to be able to best gather the details.
Those two just seem very similar to me in what they're trying, because if the newborn is affected by Zika, then it's congenital, meaning present at birth, which is P35.
But the mother may never manifest Zika, and the child may be born with signs of microcephaly and test positive for Zika. So it'd be a congenital infection. The child would never be affected by the mother.
Okay, thank you.
Thank you for the question, Teresa. Any other audience questions before we go to the phone line? Moderator, could you open the phone line, please, for questions? Okay, hearing no questions from the phone line. Moderator, you can close the line, please. And, did I hear something? Okay. Of course, if you have any further thoughts after the meeting, we encourage you to put those in writing and send them to us. I believe that is the last of the pediatric related. So with that, I will turn it over to Shannon for a presentation of the next topic. And then David should be
Good afternoon. The next topic is not in your packet. It's deep vein thrombosis. I could ask Dr. Berglund to pull it up on the screen. This is a proposal that we received and were unable to get it in the packet, but we did want to bring it forward, hopefully to have you look at these two options and comment or provide some questions that we could take back for further clinical clarification. The proposal is from the Agency for Healthcare Research and Quality, AHRQ, and they're requesting additional codes for a specific vein thrombosis in the distal lower limb. The proposal says that it would enable improved capture of these diagnoses and avoid current limitations with capturing patient safety-related events. They have sent forward two options that we would invite you to please comment on. Option one creates several new subcategories. And option two actually takes existing breakouts Perhaps we should go back to option one and maybe walk through the different new subcategories since you're actually just seeing this on the screen. So Dr. Berglund, if you could go start at option one. And here they would be proposing a new subcategory I-80.24 for phlebitis and thrombophlebitis, a perineal vein, with additional codes, further breaking out the laterality. Additionally, new subcategory at I-80.25, this one specific for muscular vein with a breakout for the laterality. Also, a new subcategory at the I-80.28 for the proximal lower extremities. Have a breakout there. And currently there's already a code, there's an existing code at the I-80.29. The first proposal also goes further to include the subcategory I-82.45 for acute embolism and thrombosis of perineal vein. Additionally, it includes a new subcategory at I-82.46 for the muscular vein, and at I-82.55 for, go up for me a little bit further, David, right here, thank you, for chronic embolism and thrombosis of the perineal vein, I-82.56 for chronic embolism and thrombosis of the calf muscular vein, with new codes again for the laterality, I-82.58 for other, and currently there is already an existing I-82.59, and this would be adding some inclusion terms. That's option one. So if we go another page, Dr. Berglund, I believe, there we go. Option 2 splits out existing codes. So we already have the I-80.29, 49 and I-82.59 codes. This would be just adding new codes at those existing codes and breaking it into a new subcategory. So are there any initial comments or questions on this proposal here in the room? I see movement.
It's hard to take it all in.
Because you're seeing it for the first time. We will post this and welcome your comments on it. We will post it as soon as we're back in the office. I'm going to go ahead and open the lines and just see if there's any additional questions or comments. Moderator, could you please open the lines? Moderator, could you please open the lines for any questions or comments?
All lines have been unmuted.
Okay. Are there any comments or questions on this proposal, understanding that this is your first time looking at it, but just wanted to see if there were any initial thoughts or clinical questions that we could take back to AHRQ for additional information if that is something that is needed as well? Comments, questions online? Okay, thank you, moderator. You can close the lines. And again, we will post this, and we do invite you to please send in any questions or comments that come up specifically for this. And this is also somewhat of a tie-in to a proposal that we had on yesterday for the phlebitis and the thrombophlebitis. And I know there was someone out in the audience that mentioned another area that we could potentially use for those codes. So I ask that you would please kind of line these two up, and you'll see what I was saying in terms of making sure that we had that available digit area somewhat available. So I ask you to please take a look at that. Okay? At this time, I'm going to turn the podium over to Dr. Berglund.
All right, we're going to page 15 in our topic packets. And this is on anemia. So page 15, anemia due to myelosuppressive anti-neoplastic chemotherapy. And this, the request for this came to us from CMS. Now, there's a lot of times where anemia occurs in cancer due to a number of different mechanisms. It can happen, of course, due to the cancer itself, or it can be due to the treatment with the anti-neoplastic chemotherapies that are used. And one of the side effects of the chemotherapy can be anemia. And that can occur in a few different ways also. One of the more common is a myelosuppressive effect. Some of the less common ones, things like aplastic anemia and stereoblastic anemia, don't happen very often. Those are more idiosyncratic reactions and are not as common as myelosuppression. The ways of coding this, now we've had ways to code things such as aplastic anemia and stereoblastic anemia, and we do have some existing codes for anemia in related to chemotherapy. We've not had a way to differentiate some of this as clearly as could be desired, though. Now, when you have anemia for certain types, for cytotoxic myelosuppressive chemotherapy drugs, they have used erythropoiesis stimulating agents to help recover from anemia. And it's been requested that we create a specific code for anemia that's due to myelosuppressive antineoplastic chemotherapy and be able to differentiate that from anemia due to antineoplastic chemotherapy via other mechanisms other than myelosuppression, that is. And again, this did come to us from CMS. Now, of course, based on the way we usually handle drug-related effects in general within ICD, we would usually be looking these up in the table of drugs and chemicals and then finding related T codes to help us identify when something is in effect from a drug. So it's requested or it is recommended also with this that we update our T codes related to this. Subcategory T45.11 is poisoning by, and we'll just look at that right now, and that looks fine there. Thank you, Tracy. That's poisoning by adverse effect of an underdosing of cytotoxic myelosuppressive. Well, basically, we do have an existing code at T45.1X. Can you scroll up just a little? We're proposing to kind of get rid of that. Actually, go back to the previous page, sorry. So this basically shows what we have there right now. At T45.1X, we've got poisoning by adverse effect of an underdosing of antineoplastic and immunosuppressive drugs. It's proposed that we expand that essentially, and the way we generally expand in these areas is we'll get rid of the 1X and instead replace it with a 1.1 and a 1.2, et cetera. So that would be the approach here. And looking at this, so I'll get back to that in a minute here. There's not also been a way to identify with ICD-10 codes whether there are adverse effects or issues related to erythropoiesis stimulating agents. This proposal did also show creation of a new subcategory, a T45.81, for poisoning by adverse effect of an underdosing of erythropoiesis stimulating agents. Whether we absolutely will need that or not isn't as clear, and we'll discuss that as we move through this. So looking next, let's look at the specific codes we're proposing. Let's actually back up and go to the top of the proposal there, actually back to the very beginning. So we are proposing to add a new code at D64.8. This is other specified anemias. 0.81 is anemia due to antineoplastic chemotherapy. That's an existing code at this time. It's proposed to expand that and create new codes within that, which would be a new subcategory. So we would create a new code, D64.810, for anemia due to myelosuppressive antineoplastic chemotherapy. We would also create a new code, D64.818, for anemia due to antineoplastic chemotherapy via other mechanisms. An inclusion term there for anemia due to antineoplastic chemotherapy via mechanisms other than myelosuppression. And a new code, D64.819, for anemia due to antineoplastic chemotherapy unspecified. So that is what we're proposing at D64. I will note that this isn't exactly what was requested, in that the request was originally to make it anemia due to cytotoxic myelosuppressive antineoplastic chemotherapy and provide a list of drugs that would go with this D64 code, which is a little outside of what we've generally done and would not follow our usual structure and convention, since we don't usually expect to look up drugs in selecting ICD codes other than through the table of drugs and chemicals and the T codes that are related. So basically this is an attempt to work with our existing ICD structure and provide some more detail both at the D64.8 and then also at T45. Moving on, looking at T45, this is poisoning by adverse effect of and underdosing of primarily systemic and hematological agents, NEC, with the point 1 being for anti-neoplastic and immunosuppressive drugs. And let's go to the next page, Tracy. And for T45.11, it's proposed that this be a new subcategory for poisoning by adverse effect of and underdosing of cytotoxic myelosuppressive anti-neoplastic drugs. And of course, then we would have, this would be for the anti-neoplastic drugs, and we would have our usual breakout there at the T codes with the 6th digit 1 being for accidental and intentional, and that also being the NOS. The .112 being for self-harm, .113 for assault, .114 for undetermined, and .115 being adverse effects of these drugs, cytotoxic myelosuppressive anti-neoplastic drugs, and .116 being for underdosing of cytotoxic myelosuppressive anti-neoplastic drugs. We would also create a new subcategory, T45.12, for poisoning by adverse effect of an underdosing of myelosuppressive anti-neoplastic drugs acting via mechanisms other than marrow cytotoxicity. And again, we would have 6 characters, 1 through 6, similar to the ones we just mentioned. The 6th character 1 being for accidental and or not otherwise specified. The 6th character 2 for intentional self-harm, 3 for assault, 4 for undetermined, 5 for adverse effect, and 6 for underdosing. We would also create a new subcategory, T45.19, which would essentially be for other anti-neoplastic and immunosuppressive drugs, poisonings, adverse effects, and underdosing for basically everything else that isn't included in the sets of things that I've just mentioned. I'd also mentioned our potential to expand and create some additional T codes for the erythropoiesis stimulating agents themselves. As I understand, some of these erythropoiesis stimulating agents can cause adverse effects, and we actually, more epidemiological studies have shown decreased survival with use of these drugs, which is concerning. On the other hand, based on these being primarily from epidemiological studies, it's not clear, well, I'm not sure whether it would be helpful to have specific codes to identify poison or adverse effects related to these, so that's less clear. So this proposal does show these. T45.8. Can we skip to the next page now? So essentially the proposal here was to expand and create it T45.81, essentially a separate subcategory for poisoning by adverse effect of an underdosing of erythropoiesis stimulating agents, and this would be useful for particularly any poisonings or adverse effect agents of these agents that was of interest, with also an additional T45.89 for the other primarily systemic and hematological agents. It's not clear if these would be helpful, and we may just retract those from the proposal if it's felt that they would not be of clinical utility. So moving on, let's go on to next page, and actually let's go to the page following this also. Looking a little farther, we don't always look at our table of drugs and chemicals. Actually, you stay up at the top there a little further, just back up 3 or 4 lines more. That's good right there, yeah. There's a very large number of entries in our table of drugs and chemicals that reference these codes, particularly at T45.1 for the essentially for anti-neoplastic agents. We've got 183 entries in our table of drugs and chemicals. And so basically we will need to be reviewing these if we're making this expansion. I do not review all of them in these lists here, but I do show some examples. Now, essentially, this list of drugs and drug classes with examples would need to be entered or revised in the table of drugs and chemicals and would need to reference T45.11, the proposed new poisoning by adverse effect of an underdosing of cytotoxic, myelosuppressive, antineoplastic drugs. These would include alkylating drugs, anthracyclines, and other cytotoxic antibiotics, antimetabolites, antimicrotubule agents, heavy metals, particularly including the platinum drugs such as cisplatin, topoisomerase inhibitor, antineoplastic agents, an example being etoposide, and vinca alkaloids. Now these include antimitotic and antimicrotubule agents, for example, vincristine. So these are some of the drugs, these are the general classes with some examples of drugs that basically would need to have references updated in the table of drugs and chemicals. And some examples of how these would look essentially are shown just further down there. Essentially, for example, then a substance for an alkylating drug, this would be revised, and right now it points to, for example, here the T45.1X1 for poisoning accidental, and that would now point to T45.111. And we would have other similar changes for each of the entries that exist there. And we would make changes along these lines for each of the relevant drugs with a number of them shown here as examples. I'm not going to read those. You can reference the ones we have here. And by extension, if you review the drugs and you check their mechanism of action, if they are cytotoxic myelosuppressive drugs, then we would want to include them referencing the new T45.11 set of codes here. So this shows how these would look. Let's go to the next page now. So we would also be considering the following to be entered or revised in our table of drugs and chemicals referencing T45.11, poisoning by adverse effect of an underdosing of myelosuppressive antineoplastic drugs acting via mechanisms other than marrow cytotoxicity. This would include anti-angiogenesis drugs. We've got a number of examples there. And I'm not even sure I can pronounce all of these properly because I didn't go to the effort of trying to look them up. But bevacizumab, sorafenib, sunitinib, pazopanib, and everolimus. So those 5 are examples anyway. There are more examples one can find. There are also epidermal growth factor inhibitors. This would include monoclonal antibodies that target the epidermal growth factor receptor, an example being cetuximab. It would also include tyrosine kinase inhibitors. These are a specific type of protein kinase inhibitors, with examples being gefitinib and erlotinib. And it would also include other protein kinase inhibitors besides just the tyrosine kinase inhibitors. And we have a number of examples of these. Essentially, all of these would be new entries in the table of drugs and chemicals. This does kind of point out that we haven't necessarily been updating our table of drugs and chemicals with all the new classes of drugs that are out there. But as far as I could tell, each of these would be new entries in our table of drugs and chemicals. So angiogenesis inhibitor would be an example, and for poisoning accidental, that would go to T45.121. And other ones would, other entries would look similar to that. So just taking those as examples, I'm not going to read the whole table. But we would have these entries, and we might want to have other additional entries to be representative. So this basically shows how these entries could look. Now, I'd mentioned the potential to expand to T45.8, but if that's not thought to have clinical utility, then we would probably pull that part of it out. So this is how these would look as currently proposed, and I'm interested in thoughts and input on how we can approach this, and any thoughts on how this should look. Linda.
So if I understand you correctly, all these individual unpronounceable drugs would all have their own entries?
We also could add the individual unpronounceable drugs too, just
I do think that
just
would
to
be
be
very
thorough.
much
And yes,
worthwhile.
we would want to do that. But we would also want to add the classes as titles just to help for cases where we do get new drugs and we don't always update our table of drugs and chemicals every time there's a new drug out.
I agree completely that we should have the general category or classification for new drugs or something that's not listed in the table. But please don't make me look up every single one of these unpronounceable drugs or have to know to go look.
Yes, the examples that I give here, I think we would want to add those to the table, and potentially some other ones. I would certainly look at that and be happy to take further consideration. A lot of times we will add drugs by name to our table of drugs and chemicals when requested, but we don't typically go out and look at all the large number of new drugs that come out very regularly, which is difficult to keep up with even for those who are following it more closely than we can.
But if you can put those individuals in as well as the class, that would be terrific. So my next question is, back up on the other specified anemias.
Yeah, on the D64, shall we back up to that section?
Can I then go to the table of drugs and I mean, I am not going to know if this, if the anemia this patient has is due to a myelosuppressive antineoplastic.
That's a very good question. So yes, that is something for us to worry about, and that would be one of the questions here. Should we be expanding as this shows to provide this other additional detail? Or does this go beyond things? And this, stepping back, this is less detailed than was originally requested, but...
I don't want to say no to CMS, obviously.
Sorry, what?
I don't want to say no to CMS, of course not, but...
the lady standing right next to you who if you said no, she just might be wanting to be mean to you or something. I don't know. Hopefully not.
I'm really very nice once you get to know me.
She looks like a nice person. I don't think she'd be doing anything mean to you, yes.
That's exactly right. I just want to be helpful.
Right. So the idea is to capture this in a way that will be convenient, will be consistent with ICD structure, and will let us capture this information in the most convenient way possible, hopefully.
Having spent the last 2 days complaining about people wanting, wanting to get codes that would never be used because we wouldn't have that kind of detail, or we wouldn't know, because it's not documented this way, I feel compelled to be consistent by the OCD that all of us have to point out that I wouldn't know unless you tell me, what do you mean by give me examples of myelosuppressive chemotherapy drugs. I understand you don't want to put a list of drugs there, but it's got to be somewhere.
That would be problematic to try to put a list of drugs there. So yes, that's an excellent question though, and that gets, I think, to exactly the issue we would need to think about.
Okay, so my name is Dr. Beth Kohler, and I work here at CMS. And I'm intimately familiar with this topic. And basically, erythropoietin-stimulating agents were the #1 revenue expenditure for Medicare. Now it's #4, but it's still substantive. So, with apologies to the pediatric orphan drugs, this is significant. And so the issue is that there are really 3 categories of drugs, causing 3 types of anemia that occur in the setting of cancer therapy. Aside from this, it's anemia of cancer, different entity, put that in one bucket. Then you have 3 other kinds of anemia that are due to treatment. The first one of those is anemia due to cytotoxic drugs that are suppressing the marrow. So in other words, cytotoxic, all that means is you're killing stuff, and you're killing it in a very indiscriminate way, and that's why you knock out marrow cells as well as your hair, you change your skin, etc. So that's one category. In that one category, the cytotoxic drugs fall into approximately 7 categories of agents. Every oncology knows them, and as a matter of fact, most internists know those 7 categories. The second category of drugs is myelosuppression not due to a cytotoxic drug. So there are these other drugs. There can be protein kinase inhibitors, they can be growth factor inhibitors, and one of these in particular is important because erythropoietin and its related entities actually not only causes the marrow to be stimulated, it also stimulates the development of vessels. So you have that agent on one side, and you have Avastin, which was the first drug on the list there. I can't say it's the first one that started with B. It was on there, but it's Avastin. But it works as an anti-angiogenesis agent, and it works by basically shutting down the blood vessels. So you have 2 agents that someone's using, and it's like a collision of the titans. So all of the work that was done on erythropoietin in this setting of anemia of neoplastic drugs was done with cytotoxic drugs. And we have these other agents that have come along. They seem to suppress the marrow, but we know nothing about their impact when you use ESAs with them. Then you have a third category of drugs, which is they are causing anemia not by myelosuppression, but maybe they're causing the red blood cells to lyse, to split apart. There can be a number of mechanisms, but it's different. And then there are always drugs that can cause issues with the marrow, aplastic anemia, which is essentially a non-functional anemia, or sideroblastic anemia, and it can do with vitamins. It's a very broad spectrum. Those are not expected effects of the drugs like I've described for these other categories. So one of the things so we've divided those 3 categories there. Myelosuppression with the anti-neoplastic agents that's cytotoxic. So there's approximately 7 categories of drugs that cause that. And then myelosuppressive but not cytotoxic. And there are 3 or 4 categories of drugs for that. And then it causes anemia, but it has nothing to do with myelosuppression. So that's a relatively small category. But we would like to know if people are going to be using erythropoietin in this area, what impact does it have? And part of the reason that we do this is that these agents have had a black box warning. And they've been used in cancer, and only the subsequent trials revealed that that there were some potential issues with them. And this was the subject of, meetings at the public meetings at the FDA, as well as meetings that we've had here. So that is what the aim is. There may be more than one way to tackle this, and I freely admit my ignorance in this, but that is that's what the goal is.
Thank you, Dr. Collard.
Thank you. Then I'll repeat another comment that I've made repeatedly over the last 2 days, which is that I have absolutely no objection to that goal. It's a worthy goal, and I have no objection to creating new codes for that. Certainly, we would want to identify that. And I would say that even if you weren't with CMS, I swear it. But my point is that if we create codes that are defined in a way that coders will not see in the medical record, then it's pointless. You still won't get good data. So it really becomes a technical matter for me. It becomes a technical matter. The objective is a worthy one, and we need to find some way to create codes. that will achieve the objective. I'm just concerned that this may not be the way to do it, because I'm going to see a physician write anemia due to chemo, anemia secondary chemo, and that's it.
Right, and so are you saying the best approach from what you think would be to keep the existing D64.81 code and then create just the T codes and use the T code together with the existing D64.81 code, and that should give us the information that we need, provided it's with the right codes?
That was actually going to be where I was going with this. You know me so well by this point, because that combination would tell us, I think, what we need to know. Otherwise, my concern is you're going to get 98% D64.819 plus a T code. So,
okay, thank you, Linda.
But I guess, to a certain extent, we've seen codes where people have to basically make an attestation. If they want to use erythropoietin, they also actually have to be putting in a hemoglobin level, etc., in order to use it. So, in a way, if you are making the physician make an attestation, with their code, they are going to know. Any oncologist is going to know if it's cytotoxic or if it's something else. And so, if you have those 3 distinct codes, you are going to answer what needs to be answered. And then if someone ultimately needs to find the chemotherapy, the specific agent, that would be nice if it in fact was linked to the code, but it's not necessary. It's more necessary to have those 3 distinct codes.
We can have the conversation together. If you want to create penalties for physicians who don't document which one of those things it is, I'm all for it. Because if there's any way to get a physician to actually document something, it's to hit them with penalties. But nothing personal. And none of this has been personal, right? There are times when physicians will document very, very specifically, but that's because there's a specific motivation to do it. Other times, if they don't have a specific motivation in place, then sometimes you just get these generic statements, and then I have to query them. I have to send a query and say, doctor, would you like to, I'm not allowed to lead them, right? So I have to say, doctor, would you like to specify if this was myelosuppressive or antineoplastic, but a mechanism other than myelosuppression? I see that the patient is taking such and such a drug, and then that's all I say. And then they ignore me because they don't want to answer their queries. So then I'm under the gun. I have to get X number of charts out per day. So you don't answer my query, D64819.
But we already have a policy that requests it. But we have a policy in place that addresses use of this agent in cancer. And so that's why someone would actually file, that's why someone would actually have to code specifically.
And just along the same lines for the anemia, hi, June Bronner, Intelligent Medical Objects again. The question I have is because of the different regimens and the different types of cancers, would a patient ever receive both types at a various point of when they're receiving treatment for their neoplasm? And I think that might make it even more challenging.
And that could certainly make it more complicated because the patient might be on a cytotoxic myelosuppressive antineoplastic agent along with one or more of the other classes of drugs. And that, of course, can make it problematic. You may not be entirely certain what caused a given anemia. There might be some characteristics of the anemia that could give you hints about that. But speaking as a physician, I will say I know physicians don't always know everything.
Yeah.
Don't let on, but we don't always know everything, of course. And so there can be uncertainty. Was this anemia due to the cytotoxic myelosuppressive agent? Or was it due to one of the other agents, particularly when they might be taken and or used together? And I don't honestly know the protocols as to how often some of these are used together. Certainly, Dr. Collar may know more on the protocols on that than I do. Dr. Linzer might have information about that, but then he might be wanting to look to oncology specialists to help him with that kind of information, I'm suspecting. He knows people who would be able to help with it, I'm sure.
Yeah, because I think that would be a big challenge, especially if the clinician isn't sure. Would it be one code, both
Yes.
codes unspecified?
Yeah, and that's a very good question, and I very much appreciate your raising it, yes.
Teresa Rahanek, Intelligent Medical Objects. Just when I first looked at D64818, I was like, what is another mechanism? And so going through the
Yeah.
rest of the presentation, it made more sense to me what you guys perhaps were trying to reach for, but I was wondering if that title should be clarified to say anemia due to anti-neoplastic chemotherapy via other mechanism other than marrow cytotoxic, something to that effect, like what you've done down further. If that's what you're trying to say, this is not a marrow suppressive, because I was like, other mechanism, what's that? And then where's immunosuppressive? Does anti-neoplastic immunosuppressive, does that need a special home also? Or will that go to D64818?
Well, that one was in a different
That's in a different home.
place
Okay.
entirely, I believe.
Okay, thank
but,
you.
Yeah, but thanks for checking on that one too. Yeah, that's something also. All right. So we do have a number of things to consider here, and definitely there are things to consider with it. How will doctors document and could we get this information in the medical record in a way that would allow most hospital coders to report codes with this level of specificity? We would like input on this, definitely. We do like to work as closely as we can with everyone, certainly, in trying to sort out codes like this. We will hope for input on this from all of you, and from both all of you in the audience here today and all of you on the phone line. And next, let's open the phone lines up for input now. Do we have questions or comments on our clinical or coding proposal here at this time? Okay, I'm not hearing anyone. Is our phone moderator still here?
Yes, sir, I'm here.
Okay, are the phone lines open now? Can we open
Yes,
the
all phone lines are
All
muted.
phone lines are open. Oh, thank you. Any comments or questions on the phone lines for our topic of anemia due to myelosuppressive antineoplastic chemotherapy? Hearing some noises, but I don't hear any questions. And with no questions at this time, I think we can move on. I will ask everyone to put all of your comments in writing, and both those in the audience here and those of you listening online, we would like to see comments in writing about this. And as you know, we do not make final decisions on what we're doing at this meeting, but we appreciate your comments, and we'll take those into consideration in making decisions. And with that, I will turn the podium back over to Donna Pickett at this time.
Well, since David's closing comments were very thorough, I will say thank you all for your perseverance and patience and your comments. We look forward to receiving your comments in writing by the deadlines in the timeline, and we look forward to seeing you at the March meeting. Thank you all. Have a good rest of the day.